Hi, this is Julia Hogan with Indiana Perinatal Network. We'd like to welcome you to our last installment of the IPN 2017 Hot Topics webinar series. This series has been sponsored by the law firm of Hall, Render, Killian, Heath, and Lyman and MDWise, and for which we are so grateful. Today's webinar is entitled Long-Term Follow-Up of Extremely Preterm Infants. Our presenter is Dr. John Wareham. Dr. Wareham graduated from the University of Texas Medical School in Houston in 1982. He works in Indianapolis, Indiana, and specializes in neonatal perinatal medicine. Dr. Wareham is affiliated with St. Vincent Women's Hospital and St. Vincent Carmel Hospital. He has also served on IPN's board of directors for 7 years and is currently our board chair. John has been a loyal supporter to IPN, and we will be forever grateful for his help and understanding. So, John, let's have you talk about extremely preterm.
All right, let's see. Do I need to click the show my screen, Julia?
Yes.
Or just...
I think you have to...
All right.
There you go.
All right. All right. All right. Well, very good. Well, welcome everybody. What I want to talk about today is almost a continuation of a webinar that we gave a number of months ago, where we talked about limits of viability and talked about what to do in the delivery room with the extremely preterm infants, and again, largely talking about the 22 to 24 week gestation group. So today I'm going to talk about long-term follow-up of the extremely preterm infant. And one of the things that is, I think, sort of a foundation of this is that survival to discharge is an important milestone in the life of a high-risk, extremely preterm infant. It's one we have obviously focused on very intently, but it is not an end point. It's just sort of a way station. And a much longer healthcare story follows the discharge in all our survivors. Couple of definitions to review again. When we talk about extreme prematurity, we're referring to infants generally born before 28 weeks. When we talk about extremely low birth weight, we're talking about babies that are born at 1 kilogram or less. What we mean by long-term follow-up is a bit of a moving target. If we had the funding and we're in an ideal world with this group of infants as they become children and adults, it'd be great to follow them into the early or into the adult years. As it is, we really struggle to get into follow-up even into the school years. What is clear is just following them up for a year or two after discharge is inadequate, because these infants are changing constantly, and a lot of the risks that these babies are going to, a lot of the risks for longer term health issues are not going to become apparent in those first few years. So why are we so concerned about this? Well, providing neonatal intensive care to this group of infants is obviously complicated. It's expensive care, and these kids are exposed to a lot of morbidity and a constant risk of mortality in the intensive care nursery. It is also clear that once we get to the point of discharge, and these babies are 38, 40, 42 weeks adjusted gestational age, we still are not discharging them as a typical term or near-term infant. These babies are different. When we looked at long-term follow-up in the past, we focused a lot on neurodevelopmental issues. I think one of the things that is a goal of the talk today is that we really need to be looking at the babies in a more global fashion. That really every organ system in an extremely low birth weight infant is going to probably mature along a different path than they would have if they'd stayed in the womb till term. And so these pathways of development are changing 12 to 16 weeks before the baby was supposed to be born. So there are nutritional, growth, renal, pulmonary, immunological, endocrine, and cardiac alterations that we have to expect along with the neurodevelopmental issues. And as with the neurodevelopmental issues, we probably are going to find that a number of these changes are lifelong and that some of these are going to have health consequences. In looking at adults who started life as extremely preterm infants, one important qualifier I want to touch on now at the beginning, and that is that neonatal intensive care is not static. It has evolved significantly over the last 20 years or so. So that the 25-year-old former extremely preterm infant that we are looking at developmentally at 2017 may not be the same as the extremely preterm infant born in 2017 that then gets looked at in 2042. So ongoing follow-up of cohorts of these extremely preterm infants is going to be important because their outcomes may well be changing. So what are we going to talk about? Most of the issues that I'm going to mention here in the next hour could be, individually could be entire talks in their own right. So then we're going to touch on a number of things, but fairly briefly. I will, through a number of studies, highlight some concerns in growth, neurodevelopmental outcome, pulmonary development, cardiovascular risk, and renal development. At the end, I'm going to give just a short update on some information on artificial placentas and discuss a template for improved follow-up of these high-risk infants. So I'm going to start out with just a little bit of outcome data. And this is from Vermont-Oxford Network in 2016, and that's a network we're all very familiar with. It has a huge database. And I'm just going to look at one little segment, and that's their 22 to 29 weeks gestation group. And in 2016, they had approximately 40,000 infants included in that group in their database. The mortality was almost 20%, although if you excluded death in the first hours of life, that dropped down to 14.2%. If you combine death with the various morbidities that we're familiar with, like chronic lung disease, severe IVH, and so forth, then that combined outcome was about 56.6%. A third of these babies would be diagnosed as chronic lung disease, which is being on supplemental oxygen at 36 weeks adjusted age. About 17% had some sort of late infection. Severe intraventricular hemorrhage occurred in approximately 11%. Severe retinopathy of prematurity in 8.4%, and necrotizing enterocolitis in 6.1%. A number that I think is really important to pay attention to is this 40,000. That even with that mortality, you're talking about 18 years, 2017, 2033, 34, you're going to be seeing over 30,000 of these infants become young adults at 18 years of age. That's a lot of patients. And that number or more is going to be there every year going forward. So I'm going to talk for a couple minutes about growth, and I'm going to focus on growth in the intensive care nursery and start with a couple of growth curves on patients that actually were in our nursery, extremely low birth weight infants. And this first growth chart is of a baby that was born at 25 and a half weeks or so. And that you see that at birth, on this growth curve, they were probably somewhere around the 25th percentile. But over the next couple of weeks, the growth the weight growth was really pretty much a straight line across and allowed the growth curve to sort of start moving away from the baby's actual growth. This next slide is of a baby that was born at 24.5 weeks. Again, started in this case maybe around the 25th to 50th percentile. And again, for the first 2 weeks, the growth just goes horizontally and the growth curve moves away from the baby's growth. And then afterwards, the baby is struggling to get back onto the growth curve. So this first article I want to talk about, Improving Growth in Preterm Infants During Initial Hospital Stay Principles into Practice, was published in the Archives of Disease of Children, the Fetal and Neonatal edition in 2016. Dr. Cook was the author. And he's at the University of Tennessee Health Science Center in Memphis. And he looked at ways to improve growth of these very small babies in the intensive care nursery. And he targeted what he called postnatal growth failure. That's very common and very similar to what those last two slides showed of a baby that in the first 2 weeks in the intensive care nursery, there is really no appreciable weight gain. And the previous charts, again, do show in our own nursery that a very common pattern of poor growth initially. Now, in the first days of life, part of that is due to fluid shifts, and that may account for some normal weight loss. However, if you account for that normal fluid loss, extremely preterm infants still are often very slow to gain weight, and it's often related to nutritional issues. Severity of this postnatal growth failure varies widely between NICUs, and that suggests that there are better approaches and less optimal approaches to supporting the nutrition. There are data suggesting the introduction of standardized feeding protocols may help with those growth issues. On the flip side is the fact that not all of these babies have the same needs, some more, some less, some just different, and that you have to have in your feeding protocols and your feeding teams some ability to individualize the feeding protocols. So there needs to be some flexibility. So why do these babies have so much trouble initially? Well, there are probably multiple reasons, and everyone's familiar with most of them. These infants are very small, they're very immature, and they're often quite sick. Enteral nutrition may take weeks to establish. The GI tract is immature like everything else, and they may have very poor GI motility. And then layered over that is the constant risk of necrotizing enterocolitis that leads to frequent stoppage of feedings and abdominal films and so forth. Then while we're trying to support these babies nutritionally, we find that many of these very small babies don't tolerate total parenteral nutrition well initially. So you have to sort of define in your own nursery how much tolerance is okay. What BUNs are you going to tolerate? What blood sugars? What triglyceride levels? And that varies a lot from nursery to nursery. There is also still a lot of discussion about what growth curves are best to use for these very preterm infants. Should we be modeling them after a fetal growth curve or something else? This is also not a homogeneous population. When you look at preterm infants as a whole, about 40% are born small for gestational age. And small for gestational age babies do not utilize calories and grow the same as babies that are average for gestational age. So why is it so important to improve growth? Well, malnutrition in infants and children is associated with all sorts of alterations in immune function, GI function, pulmonary and neurologic functions. Growth is probably pre-programmed to a point to occur at certain times. And during that 2-week window or 3-week window, whatever, in an intensive care nursery that a baby is not growing well, we may be missing windows of opportunity for growth that are hard to recover. Growth is also faster in extremely preterm infants than in term infants. The rate of growth from 24 to 40 weeks is almost 5 times faster than the rate of growth for a term infant between birth and 2 years of age. This is a very unusual time that we're watching over in the intensive care nursery. Improvement in growth by optimizing care is possible. This is something that we can do something about by providing better nutritional and support. These next couple slides are from Dr. Cook's article, and they highlight some interesting points about watching the growth of some of these babies. And this first slide on improving growth takes a 24-week gestation average for gestational age baby and has the baby attain birth weight at 1, 2, and 3 weeks of age and has them growing at 17 grams per kilo per day. And when you look up at the right upper corner, what you see on the 3 stippled lines is depending on how quickly that baby regains birth weight, big differences in how much that baby weighs at 37 weeks gestation, adjusted gestational age, going from 2792 grams for the baby that it attains at 1 week down to 2285 grams at 3 weeks. So getting these babies to grow well in that first week of life makes a difference. This next slide is a comparison of the postnatal growth in a 690 gram 24-week AGA baby and compares that to a 500 gram 24-week SGA baby. Has them both regain birth weight at 2 weeks of age and grow at the same 17 grams per kilo per day. And you see, as you hit 37 weeks adjusted gestational age, the AGA baby is 800 grams ahead of the SGA baby. Same birth weight, different starting point with the birth weight, and again, small for gestational age versus average. And this final slide, final chart from this article that I thought was interesting was just a plot of error in daily weight gain determination. And, we all know babies don't grow in a nice, steady, linear fashion. They have surges, they have plateaus, they may hit a few days where they lose weight. So if you want to guarantee the highest error in weight measurement, weigh them every day. And that gives you the biggest variation. And so, there are other reasons we weigh daily other than just, making sure they're growing and well nourished. There's other things when they're sick. But, this could make an argument that maybe you're going to get a little better feel for growth if you're weighing them 2 or 3 times a week than necessarily every day. So the recommendations from this article were that every intensive care nursery should audit growth in their unit and establish what their own local problems are, that you need a multidisciplinary nutritional support team, that you do need standardized feeding protocols, and as much as we can, those need to be evidence-based and constantly reassessed. And then as we talked about earlier, that you do need an ability to take individual babies and come up with a different plan for them because they're all needs are not the same. All right, so let's leave growth and move on to an article I wanted to talk about on neurodevelopment. And this one was titled Changing Neurodevelopment at 8 Years in Children Born Extremely Preterm Since the 1990s. And this was a study out of the state of Victoria, Australia, and involved all 4 of the tertiary neonatal units that were present in that state. The study compared neurodevelopmental outcomes at 8 years in a population-based extremely preterm cohort born in 2005. And it compared those kids to 2 other post-surfactant era cohorts, 1991 to 92 and 1997. The hope was that the 2005 cohort would show continued improvement compared to the earlier cohorts, that the survivors would be doing better. And two of the reasons they thought that the 2005 cohort, two specific reasons they thought they might be improved developmentally, was that caffeine was being used more widely, and that there had been an ongoing limitation of postnatal steroid use. So all extremely preterm infants, 22 to 27 weeks gestation, were recruited at birth, and randomly selected term infants of normal birth weight were recruited as controls. Again, they looked at those three distinct time frames, 91 to 92, so they had 24 months there, 97, 12 months, 2005, 12 months. And then at 8 years of age, adjusted for prematurity, the participants, the babies, were assessed by pediatricians and psychologists, and all the assessors were blind to what groups that the patients were in. And then they were following table I'm going to show defines the patients in the three groups. The proportion of survivors at 8 years increased in 97, then fell a little bit in 2005. Follow-up rates were very high in all three groups. They did a great job of getting these kids back. Outborn infants decreased in 1997, but more than doubled in 2005 for some reason. And postnatal steroids were used less often in the 2005 cohort than either of the two previous cohorts. So this is a big, busy slide, but just a couple things that if you looked on the second group, second list down on survivors, and that's percent of live births, that 53% of the babies survived 91 to 92, 70% in 97, and then a slight drop back down to 63% in 2005. Again, the outborn percentages, 9% in the first cohort, 5% in the second, and in 2005 up to 13%. See, antenatal steroid use was really pretty good. That in 91 to 92, 71% were exposed to antenatal steroids before birth, and that was not bad for back then. 89% and then 85% for the next 2 years, and that's probably pretty comparable to what we're used to. Postnatal, way down, about 2/3 of the way down, postnatal corticosteroids. 40% of the babies in 91 to 92 were exposed to postnatal steroids. 46% in 97, and 22% in 2005. So big drop there. And this is a slide showing the various cognitive and academic outcomes at 8 years. And if you look at IQ, the very top there, and compare the extremely preterm to control, you see going across the three different cohorts, there is a very similar, steady difference in IQ between the two groups. And it was roughly 10 to 12 points on IQ across the three time eras. When you look down at academic achievement, word reading, spelling, and mathematics, again, a pretty consistent difference that actually seemed to get a little wider as you went from 91, 92 to 2005. And that may partially be due to, and I don't think they really offered an explanation for this, is that the control group scores improved as time went on. So that made it harder on the extremely preterm group, whose scores really stayed fairly similar, but looked worse and worse because the control numbers were getting better. This is table 3 is a neurodevelopmental outcomes table at 8 years. And when you compare the three different time frames, starting at the top with major neurosensory disability. You can see that stayed pretty stable across the three groups. The IQ scores with Z-scores really stayed about the same for the group. But you do see that as in academic achievement, there was a slow or a small worsening of the scores as far as the Z-scores. And again, that was not entirely due to the controls doing a little better. And this is just another way of showing the differences in the comparing the 2005 cohort to the earlier cohorts. You see, as far as IQ scores, whether it's mean difference or odds ratios, those were all pretty similar. But when you got into the reading and the spelling and the math, the 91, 92, and 97 cohorts did a little better than the 2005 cohort. So the authors were a little bit surprised because, contrary to their expectations, academic achievement in the children born in 2005 was not improved when compared with earlier eras. How much it wasn't improved, I think, is hard to say a bit because of the change, the improving scores in the control group. However, despite adjusting for confounding variables, birth in 2005 was an independent risk factor for adverse outcome, which is really, authors did not have any kind of good explanation for. It's possible it was just a bad year, or there's maybe something else going on. I think they were surprised that decreasing the use of postnatal steroids resulted in some improvement there. The next area I want to touch on is in pulmonary outcomes. And next to the neurodevelopmental issues and survival, pulmonary area is something that we've spent a lot of time in talking about and people are probably pretty familiar with. Chronic lung disease is a very common complication of extreme prematurity, and many infants are discharged on supplemental oxygen. A few go home on ventilators. Chronic lung disease is probably one of the leading causes for rehospitalization of extremely preterm infants, and it can be from respiratory infections or complications of reactive airway disease. And so this article I'm going to talk about is Adult Respiratory Outcomes of Extreme Preterm Birth, a Regional Cohort Study. And this was published in 2015, and it came out of Norway. This study does not have a big N. There were not a ton of patients in it. I picked this to talk about because, again, they did a wonderful job of following a group of patients through many years and actually getting back a high percentage of the patients for follow-up, but the numbers aren't going to be very large. So these patients were infants born in Western Norway between 1982 and 1985, and with a birth weight of 1,000 grams or less, or a gestation of 28 weeks or less. And for each extremely preterm infant, a normally grown term infant was selected as control. A big negative to this study was that this was before the routine use of surfactant replacement. So that is a big caveat to following these kids. Haukeland University Hospital was the only regional neonatal intensive care unit involved. They went back and found this study cohort in 2000. They defined mild BPD as the need for supplemental oxygen at 28 days of age. Moderate or severe BPD was required supplemental oxygen at 36 weeks adjusted age. All of the subjects were seen twice within 2 weeks, first in 2001 and 2002 at 18 years of age. And then they were seen again in 2008 to 2009 at 25 years of age. They had spirometry and whole body plethysmography at both visits. They also filled out questionnaires on health. They got the salbutamol reversibility test at the first visit and the methacholine provocation test on the second. They also had skin prick tests and blood sampling done at the second visit, and they tried their best not to evaluate anybody within 2 weeks of a respiratory tract infection. There were 84 infants initially enrolled. 52 survived to discharge, and then they selected 1.4 term infants per preterm infant in order to get a full complement of controls. So they ended up with 46 study subjects consenting to participate at the first follow-up, 45 at the second, and 48 participated in one or the other visit, which really is quite remarkable considering you started with just 52 survivors and you are following them up at 18 and 25 years of age. When you look at this table 1, which is just the perinatal data on this group of babies, what you see as you get to the non-BPD, BPD, mild BPD, moderate to severe BPD, you're getting down to really small numbers. So that really makes splitting and looking at these smaller groups really hard to tell whether we're really seeing something significant or not. But these were small kids that, as you would expect, the ones that had moderate to severe BPD were smaller. They spent more time on the ventilator and were just generally sicker. And one of the things on these next two slides, one of the important things to note is that, and this is a slide, this next one is on the methacholine reaction or the stimulation test, and basically just testing bronchial responsiveness. And when you look at the bottom two graphs, which are the extremely preterm babies, what you see is both at 18 and 25 years of age, that these graphs for the extremely preterm babies are distinctly different at a different point on the curve, meaning that they lower down on the curve, meaning that more kids are responding to the methacholine than in the term babies above, and that it persists at all the doses. These four charts are looking at different aspects of pulmonary function, such as the FEV1 and the FEF 25 to 75%, the functional vital capacity, FEV1 divided by the functional vital capacity. And what again is important to note, and this has been found by a number of authors looking at pulmonary function in these really small babies as they get older, is that the results are distinctly different for the former extremely preterm babies than the term babies. Now, in looking at these, the z-scores are essentially around minus 0.5 to minus 1, so those aren't big differences, but they are different and reproducible, and have been found, similar things found by multiple authors. And again, these authors did a great job getting a small cohort of extremely preterm infants back for pulmonary follow-up many years after they'd been in the nursery. It's one of those things that probably only in a small country like Norway could you pull it off. The numbers were small, and all were born before routine surfactant use. Also, and possibly most importantly, the maternal steroid exposure was in the 25 to 50% range, so that's not what we're used to seeing these days. But when you look at this sort of data and you see that there are differences, my pulmonary concern has always been that in following up these really small babies is whether an inflammatory injury, such as you get from BPD or chronic lung disease, is going to lead to an earlier onset of such adult diseases as COPD. And since it is normal for pulmonary function to decrease as you get older, what happens if your peak pulmonary function is lower than normal? Is that going to mean you run into problems earlier in life? The good news from this study was that most obstructive deficits were relatively minor, and the FEV1 abnormalities that were seen did correct in many cases with giving a bronchodilator, the salbutamol. Most important lung function variables did measure within the normal limits. And on the questionnaires, when the patients were asked, very few of the subjects reported having any chronic respiratory symptoms. On the negative side, there were demonstrable differences between the former extremely preterm infants and the term controls. Again, because of the small numbers, it really was hard to tease out and really with believable data the effects of the BPD or chronic lung disease. There was bronchial hyperresponsiveness with the methacholine and suboptimal FEV1 at 25 years of age. At this point, no one really knows what this will mean with things like COPD as this population ages. However, the authors did suggest that maybe as this population moves forward, or as they move forward from infants to children to adults, that there might need to be some counseling about picking a lung-friendly lifestyle, which means things like not smoking, watching your weight, exercising, not picking a career where you inhale lots of toxic aerosols, like being a commercial painter. So they just threw that out as something that, maybe in the primary care of these kids, that's something we should be thinking about. The next thing I want to talk about is something called oligonephropathy of prematurity. And this is something that I've become more familiar with over the last few years. It's another one of those developmental issues that sort of makes sense, but really I had not spent a lot of time thinking about it. But my nephrology colleagues obviously have. And if you look at the World Health Organization, they currently look at low birth weight, a weight less than 2,500 grams, as an accepted risk factor for adult renal disease. There is also increasing evidence that prematurity, as well as low birth weight, carries the same risk. If you look at kidney development, that begins around the 3rd week of gestation. And nephrogenesis, which is laying down of the functional renal tissue, is going to be completed somewhere around 36 weeks gestational age. Maturation of the nephrons continues after that, but you don't get new nephrons. So if you're born at 22 to 28 weeks gestation, you're going to get a significant shortfall in the number of nephrons and ultimately renal size and possibly function. The more preterm the infant, the fewer nephrons are going to be in place. And in a human renal autopsy study by Rodriguez that was published in 2004, comparing extremely preterm infants to term infants, the extremely preterm infants were found to have significantly fewer nephrons than the term infants. The degree of decrease correlated with gestational age. Additionally, those babies that had acute renal injury during their life, which is a very common complication in extremely preterm infants, they had further inhibition in nephron formation. Now, on the positive side, nephrogenesis in preterm infants often does continue for a while after birth, which it does not do in term babies. However, that time period was short and still did not reach normal nephron numbers in the kidneys. Other studies have found similar results, and in extremely preterm infants, even those that have had a relatively benign NICU course, the kidneys will have fewer nephrons. Now, what does that mean? And to some degree, this is conjecture. Some of it comes from looking at how the kidneys respond to other diseases. But lower nephron numbers is believed to increase the risk of hypertension and chronic renal disease in adulthood. The glomerular filtration rate is determined by the filtration rate of one nephron and then multiplied by the total number of nephrons in the kidneys. And if you have fewer nephrons, the ones you have to compensate by increasing their filtration rate. And depending on how much they have to compensate, this single nephron hyperinflation potentially can lead to things like proteinuria, hypertension, later glomerulosclerosis, and chronic kidney disease. So as time has gone on, nephrologists have gotten more concerned about these changes. And even though we have limited autopsy data of adults who were born prematurely, that is available has shown some of the changes that people are worried about due to the increased glomerular filtration. Pediatric nephrologists now recognize extremely preterm infants as a group at increased risk for renal disease and are starting to follow them long term just because they were born extremely preterm. One of the a couple articles that I read, and this is one of those things that we just have enough information to worry about, but not really enough to know what to do to change it, is the possibility that high protein diets that we expose the extremely preterm babies to try and get growth to improve may not be the best thing for preterm kidneys. And there's, I think, some worry that maybe the kind of diet we're picking for our extremely preterm infants may not be the most kidney friendly. And then, so what are you supposed to do with that? How do you juggle somatic growth versus trying to optimize renal function as these kids mature and grow? This next article is going to jump to cardiology, and is entitled "The Reasons Why Cardiologists Should Consider Prematurity Among Risk Factors." And this article just provided a summary of known cardiovascular risks that were provided by preterm birth. And some of the risks are associated with decreasing gestational age, some with decreasing birth weight, some with both. There is extensive and increasing epidemiologic data showing an increase in heart risk, cardiovascular risk, and in mortality due to cardiovascular problems in adults that are born prematurely. The cardiovascular risk factors that appear to be increased and that have been discussed and reviewed in the literature include total cholesterol level, earlier onset of atherosclerosis, the incidence of arterial hypertension, hyperuricemia, the incidence of obesity, and the incidence of type 2 diabetes. The authors suggest that prematurity and low birth weight serve as negative influences on perinatal cardiovascular programming, and attention to the above listed factors should be part of the ongoing health care of all former preterm infants. So as far as looking at where you get your bang for the buck here, does that mean babies that are just born as late preterm, or are we going to be spending time and money just looking at the extremely preterm because they're at the highest risks? And I think that is something that is yet to be determined. Now I'm going to spend just a couple minutes talking about something that is a consideration moving forward that a couple of centers are looking at, that is discussed. I've seen it at a couple of meetings. And as an alternative to taking care of extremely preterm babies in an intensive care nursery, somehow joining them to an artificial placenta. Now, before we launch into this little summary, I'm going to have to give you a paid-for political announcement from the speaker, and that's that alternatives to neonatal intensive care, such as artificial placentas, certainly are being looked at. The driving forces behind this technology are the expense and the guarded outcome in extremely preterm infants. Artificial placentas may, if they eventually get to the feasible point, offer a better outcome for our 22 to 24 week gestation infants, but it certainly will be extremely expensive care. The real answer is still bringing our prematurity rates in line with the rest of the developed world. The U.S., as you know, really lags here. And sometimes in the United States, it sure seems like we take the approach that it's a lot easier to delve into an expensive new technology than it is to deal with a very complex social issue. So we still, we want to do something Buck Rogers instead of trying to deal with the fact that we are really do a poor job on preventing prematurity. So with that, I'll move on here. So this review article was published in 2014 from the University of Michigan and provides a brief summary of where artificial placenta technology currently stands. Much of this technology, at least as far as the pumps, has been developed and improved as an offshoot from extracorporeal membrane oxygenation, or ECMO. And as you know, ECMO has become a staple in supporting term and near-term infants that have respiratory failure, pulmonary hypertension, or are unstable coming off of heart surgery. In the late 70s into the 80s, there were several groups that began looking at the artificial placenta. They usually looked at one of several animal models, fetal sheep or fetal goats. Recently, that interest over the last 5 to 10 years has accelerated, again due to the cost, mortality, and morbidity involved in caring for extremely preterm infants. And now in extremely preterm infants, where we're talking about care actually going down to 22 and 23 weeks. Also, and this is something that has been concerning folks, is that we may be seeing a plateau in what we can do in our intensive care nursery. We haven't had anything big and new therapeutically arrive in the NICU recently. We continue to work on tweaking the things we do with nutrition, with ventilators, and so forth, but nothing big and new has really shown up lately that's going to help us do a great new job with 22 and 23 week gestation infants. So, and that's part of the reason that people continue to look at these alternatives. As you might imagine, technical issues in supporting a 22 to 24 week gestation human fetus in an artificial womb are pretty daunting. Are you going to surround the infant in amniotic fluid or cannulate and place in an isolette? If you're going to use an amniotic fluid bath, then that has been a real challenge due to infection. What vessels do you cannulate for connection to the oxygenator? Do you just use the umbilical vessels, or do you use something like an umbilical vein and a jugular vein and do veno-venous support? Some people have looked at a no pump system, which I think people have moved away from for a number of complications. But when you do look at method of cannulation in the pump oxygenator system, there have been inherent problems with vascular resistance and the development of fetal heart failure. If you can get past the issues of infection and a stable long-term circulatory system, lots of other issues are still going to remain. What's nutrition going to look like on an artificial placenta? If the system is a closed bath, what amniotic fluid are you going to use? Do you collect human and reuse it? Do you make some sort of artificial amniotic fluid? What gestation is eligible for this? 22 weeks, 21 weeks, 20 weeks, and when do you stop and switch over to extrauterine life? Developmentally, what do you do? A fetus is neurodevelopmentally designed to progress within a human uterus, listening to the mother's voice, heartbeat, etc. What do you do in an artificial womb or an isolette? Are you going to be able to mimic that in any meaningful way? So this option for care looks very daunting. but people are still working on it in a number of centers, and it really may become an option someday. I'm going to go ahead and conclude here with this last paper on outpatient follow-up of extremely preterm infants. And this article was published by Dr. Coe and colleagues, and argues that preterm infants discharged from intensive care nurseries should be considered a priority population for health care system redesign. And most of the existing postnatal guidelines focus on tertiary multi-specialty care, focusing on the problems these kids are going home with. Very few on ongoing primary care and disease prevention. One of the major complications for preterm infants after discharge is they come back to the hospital a lot. And it's most often for some complication related to the lungs, but can be for many different reasons. If you look at the risk of rehospitalization, it may be as high as 50% in the first 2 years after discharge. If the baby goes home having had prolonged supplemental oxygen need or goes home on supplemental oxygen, up to 2/3 of those babies may end up back in the hospital in the first year. So rehospitalization is very common. Also, lots of outpatient visits, up to 20 per year in the first year, many of those to the primary care doctors. So such outpatient utilization of resources is costly and time-consuming. Many or most busy primary care settings are not designed to deal with such infants. They are complicated, they're time-consuming, they're resource-intensive. And to make matters even more difficult, very little research has been done at what constitutes effective delivery of preventative care to this population. There is very little evidence-based medicine for us to fall back on. Even without a lot of data, the authors do argue that the follow-up of preterm infants needs a broad systems approach, starting with primary care. Such an approach would designate NICU graduates as a priority population and develop interdisciplinary teams based on prematurity as a whole, not just on individual encounters and problems. And this is just a theoretic mock-up on this slide of what that would look like. It's been done with a number of different disease processes. A similar approach has been taken over the years with things like asthma, but it involves coming together and putting together a medical home with some sort of patient registry, with care protocols, with decision-making support and family-centered care. There also have to be community resources and policies, some culture of quality improvement. You need a designated outpatient care team that probably still needs to include, at least for a number of months after discharge, the NICU. You have to have informed, activated families. You know, one of the things that as I put this talk together, I clearly do not do is sit down with families as they're going home with these really small babies and talk to them about renal, pulmonary, cardiac, long-term consequences. You know, that's something that I am just now starting to think about. And you need a prepared, proactive practice team. So this is just a conceptual framework, but with a number of issues, a number of things identified that would make that would be necessary to make an improved outpatient model. And again, they have used such systems in other healthcare areas, and they've worked. If you looked at the AP's Bright Futures, the guidelines for health supervision of infants, children, and adolescents, and I think the most recent version was the third in 2008, it really does not include any consensus-based guidelines aimed at primary care of preterm infants. And we do need those guidelines. And probably the more preterm the infants, the more we need those guidelines. Unfortunately, development of all the preceding is complicated by the uncertainty of our healthcare reimbursement models. And with the financial support for healthcare in such a constant state of flux, and it always seems to be in flux, it is difficult to bring on a new program without demonstrating cost savings. And ultimately, there may well be cost savings in this, but it's sort of a chicken and the egg thing. So I'm going to stop here and just give you a few final thoughts, and then see if anyone has any questions. Survival to discharge from the NICU is obviously is an important first step for the issue of long-term follow-up. But focusing on survival to discharge is really incomplete and misleading, because there's a whole lot more to what these babies need as they become children and adults as a population. The potential for all sorts of health issues into adulthood for infants born extremely preterm is real. Many of these infants are now young adults, and many more are right behind them. Many pediatricians and pediatric subspecialists are at least partly aware of these issues, but the adult physician world certainly is not. So we do need, I think, as possible, a more comprehensive system-based approach to following these kids up after they leave the NICU. But it's going to take work to design. It needs some more research, and funding is going to be an ongoing issue. There are some low-cost steps that can be taken, and communication is a big one of them. That, just as I was saying, I'm just now starting to realize there's more communication I need to do with families as these babies go home about long-term risks, and those risks need to be shared with the doctors that are going to be taking care of these babies going forward. This picture is somewhat, not entirely, but somewhat similar to the survival into adulthood of infants with corrected complex congenital heart disease. Adult cardiologists and CV surgeons are now being presented with a whole new group of patients that they are not familiar with and who do not have a well mapped out clinical course through adulthood. And so that they're sort of learning as they go. Well, the formerly extremely preterm infants are reaching adulthood, and they are going to come by the tens of thousands. And I think we really need to be putting some thought and planning into how we're going to deal with that population. So I think that about uses up an hour, and I'll stop and see if anybody has some questions they'd like to ask.
Thank you, John. That was amazing. Let's see, I've got a question here. I always have trouble reading them. So many preterm births are contributed to moms with preeclampsia / BP issues or multiples. How can we truly prevent preterm birth when we can't control maternal health, even when these moms are hospitalized and spend days or even weeks under our care?
Well, that's a very worthwhile question, and part answer to that is we can't. As long as we have moms that are getting preeclampsia and having to be delivered for maternal health, we're going to be dealing with preterm babies from that. I think we have done a better job with the multiple gestations. I think that the obstetric world has, in the infertility area, has really cut down on the number of quintuplets, quadruplets, triplets that we see. We still get some multiples, but they have done a really good job on cutting down on the higher multiples. And that's made a difference. Part of the reason we have seen some improvement in the prematurity rate in this country is our infertility doctors doing a better job. And I take that as reinforcement that, doing some improvements in that maternal fetal medicine and obstetrics does make a big difference. And the infertility docs have done a good job with that. But yes, we are stuck with some degree of prematurity and extreme prematurity if coming out of maternal illnesses that because of the mom's health, the babies have to be born early because of.
I have a question, John. This is Julia. You were talking about, so as people probably know, because I bring this up every time we have a preemie discussion, but I have my own extreme preemie. He was born 26 and a half weeks, 2.5 pounds. So, he's 22 now. How do I, it's interesting to me as I try to remind him to tell people what his own, I have BPD. Well, what's that? I mean, it's interesting that so not only do the physicians need to know, but the kids need to know what to say as they get older, and they they weren't there. They were, but they weren't. They don't remember anything. It's an interesting. I can't quite figure out who you talk to about something like that.
Well, I think that we in the intensive care nursery are going to have to get more comprehensive in how we talk to families as we come up on discharge. Mm-hmm. And that information is also going to have to filter into the primary care pediatrician and family practitioner.
Right.
And it's going to have to become something that is just known and accepted that these babies, as they become children and adults, are going to have to be followed a little bit differently.
Right.
But I think the protocols for following them have yet to been worked out. You have to be worked out. Yeah. So I think this is very much an evolving problem. But I do think that in situations like yours, you have to keep educating your son, and he's going to have to educate his adult doctors, his internist, his family practitioner, to keep an eye on that.
Right.
But a lot of that hasn't been worked out yet.
Well, it's interesting to me, and I've complained about this in the past, about how the hospitals can birth these babies, but they're not sure how to deal with.
Right.
With
it's a lot easier to think, well, we got them to survive. We got them home with a little pretty good shape neurodevelopmentally, and our job is done.
Right.
Well, it's not.
Right.
And that, I think that's sort of where we're starting to scratch our head is, we really aren't done.
Right. Okay, I've got another question. Should we be more concerned about high protein and renal function, or does brain development justify that?
Good question. I don't know. I think that, again, that all of this is very early. And, when I was getting ready for this webinar, and I read through a couple of articles where renally oriented authors talked about, these high protein diets may not be the best for the kidneys. I just sort of went, and then, well, what are we supposed to do? We want these babies to grow. We're concerned especially about how the brain grows. But I don't think we have an answer yet, or haven't anywhere near an answer about what's the balance between those two. And I think we're just starting to ask these questions, and people are going to have to start putting studies together and following and try and figure this out. But I don't think we have an answer. I think all we have now is, we probably ought to be concerned about this and start to think about it. But I would say that, brain growth probably trumps most everything. But what the question would be is, can we still support brain growth well without getting the kidneys in trouble? And we don't know that.
Can mother's milk, can breast milk help with that transition? Or are there just not enough calories in some of the?
Well, that's the problem with the extremely preterm babies. For X months after birth, we're going to be supplementing calories, protein, and calcium and phosphorus and everything into the breast milk. Mm-hmm. But, again, how much protein supplementation is optimal when you're using breast milk?
Right.
Certainly breast milk utilizes everything better than formula, So you might find that you get by with less protein in a breast milk than you do in formula. But again, those are all things we don't have answers to.
Right. Well, we're about 5 minutes over, so I probably ought to, and I don't have additional questions. If you do have a question for Dr. Wareham, please email us, and we will get it to him. We'll connect the two of you. John, we're always so grateful. You do wonderful presentations, and we're grateful for them. So,
well, glad to. They're always fun.
Good.
All right.
Okay. Thanks so much. And
oh, you're welcome.
Okay.
See you later.
Bye-bye.
Bye.